We're going to start off, this is the Spondyloarthritis pod, and a lot of new things this year. We're going to start out with Dr. Atul Deodhar, who's at Oregon Health Science University, and his talk is going to be 5 advances in spondyloarthritis. So let's go ahead and bring him on.
Thank you so much for that kind introduction. My name is Atul Deodhar. I'm a professor of medicine at Oregon Health and Science University in Portland, Oregon. And these are my conflicts of interest. So this topic, 5 advances in axial spondyloarthritis, is not going to be the typical grand rounds type of exhaustive talk on all aspects of axial spondyloarthritis. And some of you may be disappointed. You might be thinking that I'm going to speak on management of axial spondyloarthritis. And that's why I have included as a pre-learn a PDF handout. And this is our latest manuscript published last year in Nature Review Rheumatology on management of axial SPA. So if you really want to know what is the latest and the greatest in the management of axial SPA, please look at the pre-learn PDF. What I'm going to do is in the next 25 minutes, I'm going to cover 5 short stories in the field of axial spondyloarthritis. I'm going to cover these 5 short stories as the 5 recent advances, and at least 4, if not all 5, have practical importance in your practice. I'll also give you my practical takeaways from these 5 short stories which are recent advances in the field. So I'm going to cover what's happening to the epidemiology of axial SPA in the United States, and the answer might surprise you. We will then look at what is positive MRI in the diagnosis of axial spondyloarthritis. The third topic would be progression of non-radiographic axial SPA, from non-radiographic to radiographic axial SPA. The fourth short story is going to be about radiographic progression of ankylosing spondylitis, and this is the first head-to-head prospective study of a TNF inhibitor versus IL-17 inhibitor. Which of these is better in reducing the radiographic progression in ankylosing spondylitis? And lastly, I'm going to cover, is blocking IL-17A and IL-17F better than IL-17A inhibition alone in axial spondyloarthritis? All right, so let's start with a multiple choice question. Prevalence of axial spondyloarthritis in the United States is A, growing, B, going down, and C, it's not changing. So how prevalent is axial spondyloarthritis in the United States? What is the current understanding? So this is the gold standard study. This is the National Health and Nutrition Examination Survey, the ENHANCE study, which was done between 2009 2010. This is the population prevalence of axial spondyloarthritis. And the reason why it is gold standard is this is done by the CDC, the NIH, the National Center for Health Statistics. Population prevalence includes patients who have been diagnosed with this condition and also patients who have not been diagnosed. And here, general citizens are surveyed, and as shown here in the photograph, these are the big white vans which go from place to place in the US, collecting blood samples, examining general American citizens. And there are some important numbers on this slide that you probably have seen this, but these numbers are important. About 20% of general population in the US has chronic back pain. About 7% of the US population has inflammatory back pain. The US prevalence of HLA-B27 is about 6%, but that goes according to the race. So in Caucasians, it's 7.5%. In Mexican Americans, it is 4.6%. And the last bullet point is important. The population prevalence of axial SPA in the United States, according to this gold standard population prevalence study, is about 1%, 0.9% to 1.4% by 2 different estimates, say about 1%. So this is what we knew. We wanted to see what is the annual diagnostic prevalence. Diagnostic prevalence is always lower than the population prevalence because these are the patients who have been diagnosed with this condition. And we decided to look at two different Medicare free for service claims as well as the market scan claims. So these are insurance claims databases, two different databases. Market scan is more for patients who are maybe younger, who have proper insurance, which is commercial insurance. Medicare, as you know, is federal insurance. And we use two different definitions for the diagnosis of ankylosing spondylitis and also general axial spondyloarthritis. ICD-9 720.X is spondyloarthritis, whereas 720.0 is for ankylosing spondylitis. And on the left-hand side, you see a tighter definition. On the right-hand side, you see a slightly loose definition. But be as it may, I want you to look at the orange and the green dots. And if you look from 2006 to 2014, the prevalence of ankylosing spondylitis shown on the y-axis per 10,000 patients keeps on going up and up. So there is a 1.7-fold increase on the left-hand side figure and similar 1.66-fold increase on the right-hand side, whichever definition you use and whichever database that you use, seems to be the diagnostic prevalence is going up between 2006 to 2014. And we were surprised, why is this prevalence going up? So we wanted to do a second study. Now this time we looked at population between 2014 to 2019, and we used one database. This is the IBM Market Scan Administrative Claims Database. And let's first look at the table shown on the right-hand side. Again, we are using two different definitions, one tighter and one looser. The one on the extreme right, more than 2 ankylosing spondylitis diagnosis by rheumatologists, is a little bit tighter definition. And again, if you look at the red numbers going from top to bottom, the prevalence rate even between 2014 to 2019 is going up and up. Very interesting. So we have got two different studies. The first study looking between 2006 to 2014, second study 2014 to 2019. Both studies, the prevalence of axial spondyloarthritis, ankylosing spondylitis, seems to be going up. And on the left-hand side, what you're seeing is geographic variation. Idaho seems to be the place where the prevalence of ankylosing spondylitis is the highest, 13 per 10,000 patients, and in Michigan, it is the lowest, 2 per 10,000 patients. Why is it happening? Why is this prevalence going up? I think the increased prevalence of axial SPA over time is likely due to increased awareness in people. It's not that people are catching this disease. And I think we are also including non-radiographic axial spondyloarthritis. That's the reason. So while we are talking about non-radiographic axial spondyloarthritis, let's talk about what is really positive MRI for the diagnosis of axial spondyloarthritis. You know, the importance of MRI in diagnosing axial spondyloarthritis cannot be overstated. We know that this MRI is very sensitive and can be false positive. And you probably have looked at this study before. This was a study done on 20 healthy recreational runners and 22 elite ice hockey players. None of them had axial spondyloarthritis, but they underwent MRI scan of the sacroiliac joint. And the ASAS definition of positive sacroiliitis was met by 30 to 35% of healthy recreational runners and 40% of the ice hockey players. And what is this definition? This is a consensus definition of positive MRI, which states that on one slice of the image, if you see, there are two areas which show sacroiliitis, which is bone marrow edema seen on STIR image, which is the fat suppressed T2 weighted image. Or if you see two consecutive slices and there is one area which is positive, for bone marrow edema, then that is positive sacroiliitis. Clearly, this is oversensitive and less specific. What the figures show is an important teaching point. Where is this bone marrow edema in normal people? And that bone marrow edema in normal people can be seen in posterior lower ilium, as shown in the middle figure on the right-hand side, or anterior upper sacrum, shown on the top. And the very bottom figure on the right-hand side shows both. anterior upper sacrum and lower posterior ilium. That's where these are the danger zones. If somebody has bone marrow edema in these areas, that may not be because of an immune mediated inflammation, that may be just because of excess activity. Erosions were absent in this study. So 2 white spots on the MRI is not specific and is seen in many healthy volunteers. So here is an important paper, data-driven definitions for active and structural MRI lesions for diagnosis of axial spondyloarthritis in the sacroiliac joint, and what is their predictive utility. So for this, the authors looked at the original ASAS classification cohort based on which the 2009 classification criteria were developed. All these people who participated in this original 2009 classification cohort study had MRI scans done. These were read twice by 7 central readers and by 8 central readers. These are all experts, and they specifically looked for the sensitivity and specificity on SIJ, quadrant sacroiliac joint. Quadrants, there are 8 quadrants of the sacroiliac joints and consecutive slices, and they looked for erosions, they looked for inflammation, they looked for sclerosis, they looked for fat lesions. And majority of the readers, these are all expert readers, had to agree for the presence of a definite lesion typical of axial spondyloarthritis with high confidence. And they were specifically looking at candidate lesions cutoffs for achieving specificity of 95%. And even more importantly, the same people who participated in this study were followed for 4.4 years to see that they really had axial SPA even later, 4.4 years later. And so the candidate lesions cutoff achieving positive predictive value of more than 95% were selected. So very rigorous data-driven process. And what did they find? So here is the take-home message. I'm going to straight go to the bottom line here. Definite MRI lesions typical of axial SPA, there is a 3-4-5 rule. Very easy to remember, 3-4-5 rule. What does the rule say? It says that if there are erosions in 3 or more sacroiliac joint quadrants, or if there is bone marrow edema in 4 or more sacroiliac joint quadrants, or if there are fat lesions in 5 or more sacroiliac joint quadrants on one slice, and this is in the quadrants, okay, then it is highly likely, 95% likely, that this person has axial spondyloarthritis. So remember this 3-4-5 rule. All right, moving on to the third topic. Multiple choice question. What percent of patients progress from non-radiographic to radiographic axial spondyloarthritis over 2 years? A, 2%, B, 5%, or C, 12%. Here is the answer. The progression from non-radiographic to radiographic axial spondyloarthritis is variable. What this slide shows is there are multiple studies have been done on this topic. The y-axis shows the proportion of patients or the percentage of patients that progress from non-radiographic to ankylosing spondylitis, and the x-axis shows the studies and the time period on which these studies were done. So the question that I asked was, what percentage of patients go from non-radiographic to radiographic at 2 years? So look at this number, 24 months. There are 3 studies. There is a study by Ruderman, which says 2% of the patients progress. Then there is a study by Dugados, which says 4.9 or 5%. And there is a study by Podobny, which says 11.6, which is like 12%. So if you answered 2%, you're correct. If you answered 5%, you're still correct. And if you answered 12%, you are also correct. Why is it that there are different answers we are getting on this question? What percentage of patients go from non-radiographic to radiographic? And the answer is these studies included patients with different baseline characteristics. The bottom line is 5 to 40% of patients with non-radiographic axial SPA will progress to radiographic axial SPA or ankylosing spondylitis over a period of 2 to 10 years. That's the important point. Now, the baseline characteristics, wait to see in my third slide from now, I'm going to tell you which are the important baseline characteristics which predict which patient is going to progress, or the risk factors for that matter. So here is an interesting study. This is the PREVENT study. This was published now a couple of years ago. Progression of non-radiographic axial SpA to radiographic axial SpA over 2 years in the PREVENT study. This is a phase 3 double-blind randomized placebo-controlled study of secukinumab versus placebo. Patients were enrolled with centrally read sacroiliac joint X-rays. So if the expert central reader said this patient X-ray shows definitive sacroiliitis, fulfilling modified New York criteria, that would mean this person has ankylosing spondylitis. Those patients were eliminated. All right. Now, these patients underwent, and half the patients were on secukinumab, half the patients were on placebo. Placebo went up to 52 weeks. The second year of the study, everybody received secukinumab. In fact, the patients who were on placebo, even in the first year, many of the patients, they didn't want to take placebo, and then they switched to taking secukinumab. So on the right-hand side, what you're seeing, look at week 104, 3.3% of the patients went from modified New York criteria negative to positive, which means 3.3% of the patients on secukinumab developed ankylosing spondylitis, and in fact, placebo, 2.9%. I mean, does that mean that placebo is more effective than secukinumab? I don't think so. I think there are problems here is that, as I said, every patient over 2 years ultimately received secukinumab, at least for a year, and many patients in the placebo group did not receive placebo for a year. Many of them, in fact, were receiving secukinumab. But even more interestingly, look on the left-hand side, the red bullet, the fourth bullet here. When the patients had X-rays done at 104 weeks, and these 104 weeks and the baseline X-rays were given to the same experts, except the experts were not told which is baseline and which is 104 weeks, so they were blinded. 25% of the patients, the experts said, in fact, had ankylosing spondylitis at baseline. Isn't that interesting? That tells us that even experts cannot differentiate really what is non-radiographic and what is radiographic. It's completely arbitrary. The degree of sacroiliitis depends or makes the diagnosis of non-radiographic or radiographic. The point I want to bring up is it's an arbitrary diagnosis and it doesn't really make any difference. The last bullet point is also interesting. These were non-radiographic axial SpA patients, and about 15% of them had already had syndesmophytes, and we still call them non-radiographic. So even that name is a misnomer. So in the same study, if you look at the spine, which is shown in the cumulative probability plot on the left-hand side, 97% of the patients either on secukinumab or placebo had no radiographic progression over 2 years at all. On the right-hand side, it shows that the mean change in the sacroiliac joint MRI bone marrow edema score, and as expected, secukinumab suppresses the bone marrow edema. Not surprising, it's an IL-17 inhibitor. Compared to placebo, there is much more bone marrow edema suppression. All right, so monitoring of axial SpA patients, I said that there is a difference in the baseline characteristics of the slide that I showed you earlier, based on which the radiographic progression is dependent. So what are the risk factors for radiographic progression? Mostly in the spine, but also in the sacroiliac joint. Number 1 is male sex. Number 2, smoking. Number 3, active inflammation. Patients with high CRP and patients who have active inflammation on the MRI have progression, radiographic progression, compared to those with low CRP or no inflammation on the MRI, and pre-existing syndesmophytes, and also positive HLA-B27, and also blue-collar workers. These are some of the risk factors for radiographic progression in the spine and in the sacroiliac joint. The last bullet point is important, and this comes from the ACR SAA Spartan treatment recommendations, that in daily practice, routine monitoring by MRI is not required. CRP should be monitored. One can do MRI of the sacroiliac joint to see if the patient is not responding, to see whether the drug has taken away the inflammation or not. But routine monitoring is not required. And really, there is no need for routine spinal X-ray, and certainly no need for sacroiliac joint X-rays to see whether a patient has gone from non-radiographic to radiographic. Because as I said, even in the expert hand, 25% of the time, They make a mistake themselves. If you show them the x-rays 2 years later, they suddenly say, oh, this person has ankylosing spondylitis, when 2 years before they had said this patient has non-radiographic axial SPA. All right, that brings us to the fourth topic here, radiographic progression in ankylosing spondylitis. The previous one was radiographic progression in non-radiographic. This is the first ever head-to-head study of TNF inhibitor versus IL-17 inhibitor. This study is SURPASS study. This is not even published in full form yet. I've taken this from the late-breaking abstract from last year's American College of Rheumatology meeting. Secukinumab versus adalimumab biosimilar head-to-head study to assess radiographic progression in ankylosing spondylitis. The hypothesis was that secukinumab is better than adalimumab in preventing or in reducing the radiographic progression. These were active patients with ankylosing spondylitis, and these were chosen to have all the risk factors that I told you. Nearly 80% of the people were males. Their mean high sensitivity CRP was 20, quite high. 73% had pre-existing syndesmophytes. So these are the risk factors for progression. These people who enrolled into the study were destined to have more radiographic progression. And the primary endpoint was proportion of patients with no radiographic progression. That means the MSAS change of less than or equal to 0.5. And these patients had X-rays and MRIs at baseline and X-rays and MRI at 2 years. 3 central readers, again, they read the X-rays before, they read the X-rays at 2 years. They were blinded for treatment and the chronology of the images. And here are the results. The primary endpoint was not met. The idea was that secukinumab will be better. However, there was slight numerical benefit for secukinumab, but really no statistical difference. 66%, nearly 67%, and 65% patients had no progression. So slight higher number in the secukinumab, but this is not statistically significant. Both the secukinumab 150 milligram, 300 milligram, adalimumab biosimilar, they had very similar number of patients. If you look at the table on the left-hand side, it shows you the change from baseline in the MSAS. For secukinumab 150, the change from baseline is 0.54, secukinumab 300 milligram 0.55, adalimumab 0.72. Again, slight numerical difference, not statistically different. So it was a negative study. And if you look on the right-hand side, the cumulative percentage plots, they lie one on top of the other. What does that tell me? So my takeaway is technically the SURPASS study is negative. However, the spinal radiographic progression over 2 years in this population of patients who were destined to actually progress more, high number of males, high number of inflammation, existing damage, these are all risk factors. The spinal radiographic progression was very low, less than 1 MSAS point. And there was no significant difference between secukinumab and adalimumab. So it appears that IL-17 inhibitor is as effective as TNF inhibitor in preventing radiographic progression. I think this is a good news. And the last bullet point is, once we start our patients on the biologic, whether it is IL-17 or TNF inhibitor, and ask them to stop smoking, we can't do anything much more than that to prevent radiographic progression, because as you can see, whether they are on TNF inhibitor or IL-17 inhibitor, their progression is very low over a 2-year period. Lastly, is blocking IL-17A, how are we doing for time? Yes, we have got a few minutes. How is blocking IL-17A plus IL-17F different than blocking IL-17A alone? Is it better? So this is the bimekizumab study in non-radiographic axial SPA and ankylosing spondylitis. 2 different studies. B-Mobile 1 was non-radiographic. B-Mobile 2 is ankylosing spondylitis. And this is recently published in January of this year. So bimekizumab inhibits IL-17A and F. Both studies met their primary analysis, primary endpoint, which was at week 16. It was ASAS-40 as shown in the top. Those line graphs, and compared to placebo, the drug was effective, not surprising. This is IL-17A and F inhibitor. The bottom colorful graph shows that the ASDAS disease state, the red, which is the baseline, then the middle one is week 16, and then week 24. As you can see, as we go from baseline to week 16 to week 24, the green becomes more and the red becomes less. Red is the high disease activity or very high disease activity. Green is low disease activity or inactive disease. So by end of 24 weeks, about more than 50% of the patients on bimekizumab have either low disease or inactive disease. So straightforward study, bimekizumab works. The question is this better than IL-17A inhibitor alone? And difficult to say because this study did not include, for comparison, what happens to IL-17A inhibitors. However, there's some curious things about this study. If you compare biologic naive and TNF inhibitor inadequate responder patient within these two studies, so both studies, B-Mobile 1 and B-Mobile 2, included small number of patients who were TNF inhibitor inadequate responder. On the left-hand side, what you're seeing is ASAS-40 responses in non-radiographic XLSPA, B-Mobile 1 study, TNF naive and TNF inadequate responder. And the same thing I'm showing you on the right-hand side in ankylosing spondylitis. And as you can see, the responses are similar, at least the difference in the bimekizumab and placebo. And now you're definitely going to say, oh, the numbers are small. And you're correct. The numbers are very small in the TNF inhibitor inadequate responder patients, only 17 here and 10 there. One patient here and there can make a difference in the non-radiographic. Look on the right-hand side. Here also the numbers are slightly better, still small, 17 and 37. The difference between the placebo, the delta looks quite good. However, yes, I agree, numbers are small. What happens in psoriatic arthritis? So this is bimekizumab in psoriatic arthritis, biologic naive and TNF inhibitor inadequate responder. Here the numbers are not small. These are two different studies. B-Optimal study on biologic naive, 852 patient. This is ACR 50 response, shown on the left for a biologic naive in B-Optimal. On the right-hand side, B-Complete. This is TNF inhibitor inadequate responder patient, 400 patient. Again, here, now these are two different studies we are comparing, but the delta looks very similar. Here is delta. Looks very, very similar. So both studies met primary endpoint and response looks comparable. And lastly, looking at bimekizumab in psoriasis. Here the primary endpoint is PASI 90 response by number of prior biologics. So if you look at the line graphs on the top, 0 biologic, 1 prior biologic, 2 prior biologics, and they're all lying one on top of the other. So again, it appears that there may be, and so I've shown you now non-radiographic XLSPA, ankylosing spondylitis, psoriatic arthritis, and psoriasis. There appears to be that in patients who are TNF inhibitor inadequate responder patients, they still get as good a response, maybe, compared to those who are TNF inhibitor naive. At least there is a signal here. Is there a biologic plausibility? And this is my second last slide. Are TNF inhibitor inadequate responder patient immunologically any different? So I'm showing you a study which was published. This is an abstract by Siebert, Stephen Siebert. This is taken from guselkumab. So this is serum samples from Discover 1, Discover 2, Cosmos. These are 3 studies on guselkumab in psoriatic arthritis. Serum samples were collected and they looked at patients who are TNF inhibitor naive and TNF inhibitor inadequate responder. And they looked at the baseline IL-22, IL-17A, IL-17F, IL-6, CRP and SAA levels in that serum. And what you see here, those circles, is patients who were TNF inhibitor inadequate responder, the baseline serum levels for IL-22, IL-17A, and IL-17F levels from pooled treatment groups were higher in TNF inhibitor inadequate responder than naive patient. Maybe that's the reason why blocking IL-17A and IL-17F in this particular population of patient gives you such a good response. Just a theory. All right, my last slide. What did we learn? Prevalence of XLSPA in the US is going up. We are diagnosing XLSPA more. There is a better recognition, and we are diagnosing non-radiographic XLSPA. And now we have data-driven definitions. Remember the 3-4-5 rule for erosions, BME, and bone marrow edema, and fat in the sacroiliac joint quadrants. Variable number of non-radiographic XLSPA patient progress to radiographic XLSPA depending upon the baseline risk factor. but X-ray monitoring is not needed. IL-17 inhibitor appears to be as good as TNF inhibitor in preventing radiographic progression in AS. And lastly, is blocking IL-17 A plus F better than just A? We don't know. Time will tell. Thank you so much.